Just surviving.
I thank God for that today.
Oh,
In Spencer.
good.
They saved my life this morning.
Is that okay just to do it from living in there?
Sure.
Yeah, at work. Thank you. And my Spencer.
Is that good?
Yeah, it's perfect.
You guys are the best.
All right.
Cool. All right. Good morning, everyone. For those of you who haven't met me yet, my name is Fitz. I'm one of the CA1s, soon to be CA2 in 5 days. And I'm going to be talking this morning about anesthesia classifications and scoring systems. So just jump right into it. Let's start off with a small little clinical scenario. So you're the PACU nurse and you're just starting your shift for the day. The charge nurse notifies you that a patient has been assigned to your PACU slot. You print off your summary sheet of the procedure / intraoperative events, and you wait for the team/patient. The patient arrives and there's no immediate concerns. After monitors are hooked up, you ask the team for their names and their pagers, and then sign out begins with the anesthesia provider stating the following. This patient is a 52-year-old female, ASA 3E, and her airway is a Mallampati 2, grade 3 mask, and she has a grade 2A view with a hyperangulated glide. And you stop and you look like this. Trisha told me that I could use memes and try to spice this up a little bit. So that's what I try to do. And you're like, aspirin, she drives a Maserati, what grade did she get? And and my favorite Homer Simpson meme. Can you repeat the part about the stuff where you said all about the things? So before we get into the rest of it and what that stuff means, I'm just going to give you a little bit about myself and my upbringing. So my family is from the Caribbean. Yep. The beautiful islands of St. Martin and Dominica. Most people have heard of St. Martin. Not everyone has heard of Dominica. It's different from the Dominican Republic, even though it's spelled the same. And so this is my family here. Just me and my mom, my little self. And I was born in New York. I was raised in Southern Long Island. And then this is my little brother, me feeding him. And once they had him, then we moved to Michigan when I was younger. Small fact about myself also, my first name is just Fitz, but my middle name is Gerald. So it's a caveat that's separate. Yeah.
Gary.
My whole family actually calls me Junior because I am a junior. But then I grew up in West Michigan, Grand Rapids area, west side of the state. From an education standpoint, I'm first generation American because my family's from the Caribbean. I'm also the first in my family to go to college and thus med school. And I went to U of M for basically everything. I did the School of Kinesiology. I majored in movement science and minored in biochemistry, class 2014. And then I was here for med school and I did the dual degree MD, MPH, and I got a MPH in healthcare management and policy in 2020. Of note, because of COVID, I didn't have a med school graduation, so it's kind of bittersweet. But and then this is just some pictures of me in med school, public health degree to graduation, and now finally here in the PACU. Some hobbies about myself. I like to restore old sneakers, and so these are the same shoe. Some Nike Air Forces that I play around with. And then I like to go to concerts. This is me standing on a couch. I don't advise you to do this. I also play soccer. I'm an avid soccer player, and I still play. I'm still in the league. I play about 2 times a week. And then this is me and my mom and my brother at the Liverpool Man United game some years back at the Big House. And then in my spare time, I like to do photo shoots with my friends. But this is actually a business that I started in med school with some of my closest friends. And so this is one of our business shoots. Lastly, my most recent hobby, everyone picked up something. Everyone kind of like picked up something during COVID. And my thing was I got into cocktail making with due reason. But being cooped up in the house is not really much today to do other than kind of binge watch shows and make some drinks. So this is my bar that I built over the summer. And stay tuned. I got that at the end of the presentation. It is just orange juice. Yeah, it's just orange juice. Now getting into the actual educational portion of this. So ASA classification. First off, what does ASA even mean? It's not aspirin, but it stands essentially for the American Society of Anesthesiologists. And ASA is basically, when we say ASA 1, ASA 2, ASA 3, it's basically just a physical status classification that we use to assess and quickly communicate a patient's pre-anesthesia comorbidities and things that they may be associated with. And so the classification system alone does not necessarily predict the risk of associated any perioperative risk, but it can be used with other things that we use to quantify the risk that a patient may have for adverse events going through with the surgery. So it's scored on a system from 1 to 6, hence how you hear us say, oh, ASA 1, ASA 2, and there's various different classification tables out there. Most of them come directly from the ASA themselves. And so going through kind of each of one, ASA 1 is in normal healthy patients, which is pretty satisfying. ASA 2 is a patient defined as mild systemic disease that is controlled. ASA 3 is a patient with severe systemic disease. And ASA 4 is a patient with severe systemic disease that is a constant threat to life. And then 5 and 6 aren't really pertinent to you guys here, but 5 is a moribund patient who is not expected to survive without the operation. More times than not, they'll probably end up direct transfer to the ICU as opposed to coming to the PACU. And then the ASA 6, just for inclusion, is basically a brain dead patient who is an organ donor. Additionally, sometimes you might see an E attached to some of that. So maybe ASA 2E, ASA 3E, and all that means is that the procedure itself was an emergency. So some examples of ASA 2 would be with mild systemic disease is someone who is a current smoker but does not have COPD, someone who is a social alcohol drinker, someone who is obese, specifically with a BMI of 30 to 40, someone who has well-controlled diabetes and hypertension, mild asthma, as well as pregnancy. And important to note is that pregnancy is not necessarily a disease state. It's just the physiological changes that accompany pregnancy can alter some of your hemodynamics that can make you a little bit higher risk for surgery. And then Trisha also told me that people use like pictures of their dogs and family and things like that to spice up. So I chose baby pictures of me and my brother. So I'm gonna just incorporate a couple of those in between each slide. And it's funny because we actually, if you look at a lot of our baby pictures, we look exactly the same, but now we look completely different. So my brother is on the bottom and I'm on the top, but yeah, right? It's hard to tell, right? It looks like the same baby, right? I actually remember I posted a picture on my Instagram some years back in like high school or something like that. And my mom was like, that's not you, that's actually your brother. I was like, well, it looked like me, so. ASA 3, some of those examples of severe systemic disease is someone who has poorly controlled diabetes and any associated complications that may be with that. Poorly controlled asthma, a COPD, whether they're a smoker or not, and then morbid obesity greater than 40, as well as alcohol abuse or dependence. And some of the cardiovascular diseases, as well as anything with uncontrolled hypertension, anything with an implanted pacemaker or some type of cardiac device, anyone who has a mild reduction in ejection fraction from heart failure, and stable angina. And then lastly, anyone who's had a history of an MI, a stroke, or any type of cardiac related events outside of 3 months, so not recent. And then lastly, end-stage renal disease if they're on regularly scheduled dialysis. And this is my favorite picture of my little brother.
What's the age difference for you two?
6 years. Yeah, 6 years. Yeah. And then going over ASA4 examples. So this is specifically any diseases that have. About what? Wait, what age? What ages? What ages? Oh, okay. I don't We'll talk about that later. I'm dead. So a couple of couple examples of this is so anyone who's had a recent MI or any of these cardiovascular events within the last 3 months, anyone who has ongoing cardiac ischemia or any severe valvular dysfunction and specifically unstable angina. And then anyone who has severely decreased ejection fraction with heart failure or any symptomatic congestive heart failure. So someone, for example, who may have heart failure but may be controlled, they would be ASA3, but if they're acutely asymptomatic or have changes in symptoms and they're presenting for surgery, they automatically would be an ASA4. And then anyone obviously in shock, sepsis, DIC, and then end-stage renal disease if they're not scheduled for dialysis. And this is me. Yeah, the little suspenders. And then ASA5 is not really relevant to you guys, but again, this is someone like ruptured abdominal thoracic aneurysm, someone with a specific like really bad trauma or any intracranial bleed with associated mass effect. It's my brother. So a quick question here is just which of the following descriptions would most correctly correlates with an ASA physical status of 4? So a diabetic patient with a hemoglobin A1C of 8.4, a hypertensive patient with chest pain at rest, or an atherosclerotic patient who suffered from a stroke 2 years ago, or an elderly patient with necrotic bowel and acute on chronic renal failure. Any guesses? D? D, okay. Any other? Okay. So, exactly. Yeah.
Oh, me? I didn't hear you.
So in this example, yeah, so the answer would be B because it is the person has chest pain at rest, which would be considered unstable angina. And some of the other ones, essentially A and C, A would be an ASA3 because they have diabetes, but it's just poorly controlled. And then C also would be, they have had a stroke or an MI, but that was greater than 3 months. So it's not recent. So they still would be ASA3. And then lastly, the last patient would be ASA5 because someone with necrotic bowel is, unless they have, specific surgery for that, that could be life-threatening. Yeah, so moving to the Mallampati score. So this is essentially just a simple scoring system with a range from 1 to 4. And all it does is it basically is a visualization of the airway. You specifically just ask patients to open up their mouth. And when we do that, we're basically just looking at the amount of their mouth opening to the size of their tongue. And based on that, what we can visualize, whether it's the hard palate, the soft palate, the uvula, or the pillar, the tonsillar pillars, that can provide us with an estimate of how easy or hard their oral intubation may be with DL. And so it's basically just one of the clinical signs that we use to assess or predict difficult intubation. There's me in more suspenders. And so when we talk about Mallampati 1, 2, 3, 4, all that is just basically just kind of seeing how much of the anatomical structures can you visualize with the patient that's sitting up. And they say Mallampati 1 is basically just, you can see all of those structures. And then you grade all the way to a Mallampati 4, which is you can only see or visualize the hard palate. There's a bunch of other different things that aren't really relevant to you guys back here in terms of predictors of difficult like intubation airways. It's just to note that this is just one of the things that we use amongst many criteria. And all of these have been specifically studied and correlated with associations with difficult intubations or difficult airways. And all of these questions are exactly the same questions. If you guys in pre-op, you'll hear us ask patients to, can you open up wide? will measure kind of their thyromental distance, is basically the distance from the top of their chin down to their thyroid membrane. And then we'll assess like their neck flexion, neck extension, all those different type of things. So these are other things to consider if you have a patient back here. This is my brother again. And then other grading classifications that you might hear us say is basically grade mask, a grade view. Grade mask is basically essentially what it is. 1 is always the easiest, there's no issues. And then you go up to all the way to grade 4. I think the things that really for you guys back here, if you hear grade 2 or grade 3, sometimes you see patients come out with an oral airway, and that automatically would mean that they're a grade 2, which means in your head, you should start thinking that, okay, they have some type of obstructive pathology, whether it's OSA or just anatomical situations that could lead to obstruction of the airway. The other thing to note is that for grade 3, there we go. For grade 3, I think the biggest thing is if you hear someone say grade 3 is to clarify what does that mean, because grade 3 essentially is defined as a difficult mask cannulation, but that can be anything from maybe it just took 2 providers to hold, 1 person to actually hold the mask with 2 hands on their mouth, and the other one to squeeze a bag, and maybe that was sufficient. Or it could mean that it still took 2 providers, but it still couldn't get a good seal. Maybe they have a really bad beard and we're moving air, we're still ventilating, but it's still very, very difficult, which is 2 very different situations. Yeah. So that's the only kind of caveat for the grade 3. So if you hear that, you don't be afraid to clarify, what do you mean by that? My brother running track. And then the other thing, which is also not relevant, when we say grade view, if we're talking to other providers, that's just basically showing the actual direct visualization of the vocal cords when we are looking to intubate. And again, it ranges all the way from 1, which is a great view, all the way to grade 4, which is a bad no-no. So now going back to our clinical scenario. So again, so you get to sign out and you hear a patient that's a 52-year-old female, ASA 3E, and her airway, was a Mallampati 2, grade 3 mask, and she has a grade 2A view with a hyperangulated kaleidoscope. So now that you've gotten kind of the basics of what that may mean, what that jargon may mean, and how that may be relevant to you here in PACU, I think you're pretty ready to kind of tackle what does that mean. So thoughts, things that you should consider is essentially, okay, so they're likely a sicker person, ASA 3, at baseline. It wasn't emergency surgery, so just because of that, they might be potentially higher risk for perioperative adverse events, which includes being in the PACU. And their airway may not be straightforward. So they're a fairly difficult mask. And you know that if in the situation that you needed to, if there was no providers, acutely around and they were becoming hypoxic, you'd probably be able to bag mask at to the bare minimum. And then lastly, you know that in your fail safe that they at least are able to be intubated with it if that needs to be a rescue plan. So now, what is this relevance essentially to you guys in the PACU as nurses? In essentially, the summary is that ASA classification is just a quick way for us to just quickly, from provider to provider, have some type of baseline of how sick or not sick is this patient. If I say an ASA 1, I know automatically, I don't have to know what associated diseases or things they may not be. I already know that they're a pretty healthy patient, which you never really see here. That tends to be outpatient, Eastern Arbor, things like that. If someone is an ASA 2, I'm starting to think like, okay, they're not sick, but they may have some, diabetes, maybe some hypertension that's well controlled. So I'm still fairly comfortable. If someone comes in and says ASA 3, which is probably, at least more than half of the patients here, that's when you start thinking like, even before you get signed out, you don't even have to know anything else about their past medical history. You just know off the bat that they're probably a little bit sicker. That just kind of helps you know, like, maybe you have 2 slots, you have 2 patients and you have ASA 2 and ASA 3 in one. It's just something that to note that maybe I should, I might have to give a little bit more attention to my ASA 3 patient. And again, airways, from the airway scores and the grading systems, these are basically used to visually assess the risk of a difficult intubation. And then for you guys out here, it's basically the risk of any type of obstruction or obstruction through the airway that may be a reasoning for their hypoxia, especially after getting general anesthesia, and as well as any like actual attempts that we may need to do an actual intervention. So essentially the cheat codes and the shortcuts to remember, because you don't really need to know all the numbers and what the different classifications, because that's not too relevant to you guys. But for any ASA classification, for a Mallampati score, for a grade, whether it's a mask or view, you only need to remember the numbers 1 through 4. And for all of them, number 1 is essentially everyone's happy place. So whether you hear grade 1 mask, grade 1 view, Mallampati 1, ASA 1, all of the ones are, regarding, even if you're not sure what each of those definitions mean, they're fairly healthy. And then if you start hearing 4s and 3s, that's other things to consider. I think it fell off. Sorry about that. But essentially, if you hear 3, this is kind of your kind of like tip off to know that this patient may be sicker, maybe have a difficult airway, and they're more likely to obstruct, especially in the postoperative area when wakening from anesthesia. And so that is something that could also be at the top of your differential for hypoxia or even hypercarbia, especially patients who come out with sleep apnea machines. And then this is the drink, my summer drink of choice. So I've really been dabbling with like margaritas first, and like mezcalritas, if you like smoky drinks. And so I came up with this, and I've made it a few times for my friends and a couple gatherings, and people tend to like it. Essentially, it's just a blue prickly pear margarita. You have to use 2 ounces of Blanco tequila, make sure it's white. And then why? Because I'm learning that with mixology, everything is all about the presentation, which I thought was pretty cool. And so the colors and the different color palettes that you come out are based on the color of the actual liquor that you use. So if you were to use dark tequila on this, it wouldn't come out as a nice summery blue, which is why I use white tequila. And then some fresh squeezed lime juice, make sure it's fresh, some blue curacao, and then some prickly pear syrup, or just simple syrup if you don't have that. And then if you're not on the sweeter side, you can just actually avoid that altogether. And I kind of like my margaritas straight, but some people like them a little sweeter. And then you mix all the ingredients, shake them, and you serve the garnish. And then if you want a little extra bite to it, you throw in 1 ounce of ginger beer, which is kind of like also a little Caribbean mix, but it gives you a little bit of a ginger taste to it, which is kind of nice. So, and that's my presentation.
So we can judge.
It's good. It's good. What'd you say?
You and your brother is like now picture.
Oh yeah, I didn't. Yeah, I should put the. I didn't
What
put
does
the
he look
current
like
picture.
now?
Older, I guess.
That's a great job. Can I just add one thing? I think that all these scoring mechanisms are important to know from our standpoint. If it's a higher number, like if you're 4 and you see that things are not getting the right direction, we want to know about it earlier, because the likelihood of patients decompensating or us having a harder time to manage working with you, like prop the airway or mask, it's going to be a lot harder for us. So the earlier we know, the better we can get on the plan to try to avoid like evasive action or something like that. So if you're 3 or 4, come and let us know a lot earlier than someone with 1 or 2, because they're likely to decompensate a lot faster, not have the reserve medically to tolerate things. And so it's much better to come and have a chat, have us come and look at the patient early so that we can figure out if it's really a real issue or not. And then there's surgical issues that I think also can impart additional concerns on the scoring mechanisms that you hear about, because when we do the assessment at pre-op or we intubate the patient in the OR and we see what we see, that's at the beginning of the case. But then there could be an ENT surgery or a thyroid surgery, or actually there could have been additional attempts, or even just that initial attempt could have actually caused a little injury to the airway. And like there can be airways that are actually worse coming out from something that happened with intubation or the surgery, the length of the surgery, the amount of fluid someone got, airway edema, the head down positioning. We get a lot of people that have surgeries where the surgeons need the head all the way down to get venous congestion. And so that could exacerbate someone's, if they've already got a big, thick, obese neck and things like that, it could actually make it even more challenging to manage them for a period of time until that venous congestion goes away. I'm sure you guys have seen people come out with swollen looking faces and things like that. So I think that letting us know early is the key. I do the same thing when I'm in the unit. Like if I see something that I'm concerned about related to like a surgical patient and, it was like a complex surgical issue, I called surgeons early. I'd rather bring it up early and have a conversation and then find out, they're okay with it at this point in monitoring. We're all on the same page rather than waiting.
Yeah, good point.
Thank you.
Good point.
Awesome job. That's
Yeah,
awesome.
thanks.
That was really good.
Appreciate it.
Any questions in the chat? Very nice. Cool.
Yeah, thank you. Do you need me, or I guess you already emailed it, you don't need anything else from me.
No, I don't think so. You did a great job. That was
Thanks.
awesome.
No
Thank you.